Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
This is Expert Perspectives in Chronic Graft versus Host Disease, and we're delighted to be joined by Dr. Corey Cutler, Dr. Zachariah DePhillip, and Dr. Miguel Angel Perales. Do you want to introduce yourself, Dr. Cutler?
Of course. I'm Corey Cutler. I'm the director of the Stem Cell Transplantation Program at the Dana-Farber Cancer Institute in Boston, Massachusetts.
Okay, and Dr. DePhillip?
Yeah, my name is Zach DePhillip, and I'm a transplant physician at Massachusetts General Hospital in Boston.
Great, and last but not least, Dr. Perales.
I'm Miguel Perales. I'm the chief of the adult BMT program at Memorial Sloan Kettering in New York.
And the focus question is sort of in broad strokes, how is graft versus host disease prophylaxis, so how and why is it so critical? And then what are the major advancements that we have been seeing, and then what might the future hold? So Dr. Cutler, do you want to start with this one?
Of course. So GVHD would be a universal phenomenon in the absence of some form of graft versus host disease prophylaxis, be it pharmacologic or a graft manipulation strategy. The standard of care has been tacrolimus and methotrexate, or another calcineurin inhibitor with methotrexate, for the past 20 plus years. And we've actually been working very hard to try to improve upon this. There have been two important advances in the field in the last few years. The first is the addition of the costimulatory blockade agent abatacept, which has been shown in mismatched unrelated donor transplantation and to a lesser degree in matched unrelated donor transplantation to reduce the incidence of acute graft versus host disease without affecting the incidence of chronic graft versus host disease to a great degree. The second and perhaps more impactful advance in the last few years is the resurgence of the use of the post-transplantation cyclophosphamide regimen, originally developed by the Hopkins group, whereby cyclophosphamide is given as a cell cycle specific agent to kill off alloreactive T cells in the early post-transplant period. This approach has been associated with both a reduction in acute and chronic GVHD, both in the severity and the incidence. It's been proven in a randomized trial, particularly in the reduced intensity setting, to be better than the currently accepted standard, which was tacrolimus and methotrexate. That being said, there are other approaches that the field is taking. We have other agents that we know are active in the therapy of acute and chronic graft versus host disease that we are working on to try to prevent both acute and chronic GVHD. Examples of agents here are things like ruxolitinib, which is active as a therapeutic and will be tested as a preventative agent. It's also worth noting that there have been significant advances in graft manipulation strategies that may impact the overall incidences of acute and chronic graft versus host disease. And I refer mainly to work that's being done both at the Fred Hutchinson Cancer Research Center with selective T cell depletion, and then some work that is being done by a private company looking at a graft manipulation strategy.
Wonderful, thank you. Dr. DePhillip, do you have any thoughts on to dovetail with Dr. Cutler's comments, or to further extend the discussion here about the prevention and prophylaxis?
Yeah, sure. So, when thinking about GVHD prophylaxis, I think some of the characteristics we would think of when we're thinking about an ideal regimen is something that's effective, safe, and also logistically simple. And I think that's really where post-transplant cyclophosphamide has been able to kind of push the bar for excellence, in that we can see across the board, as Dr. Cutler was mentioning, not only in the setting of a HLA matched transplants, but also our mismatched transplants and haploidentical transplants, that cyclophosphamide is able to result in low rates of both acute and chronic GVHD And it's something that we all have access to, not only here in the States, but across the world. And it's been easy to implement from that perspective. I think it's interesting because it also sets a high bar in terms of being able to address both acute and chronic GVHD prevention. So we've had other agents in the past that have maybe been very effective at preventing acute GVHD, but still have a moderate to significant amount of chronic GVHD later on. And I think that some of those approaches may yet need to be modified some in order to see if better chronic GVHD prevention can be achieved. So for example, Dr. Cutler mentioned abatacept, which is FDA approved in the prevention of GVHD. That preliminary study that supported its approval did not really show a impressive impact on chronic GVHD, but there are now new ongoing studies looking at different dosing strategies to see if that can be further improved on with the agents that we have available. So there's still room for improvement, as Dr. Cutler mentioned. And a lot of what we're looking at besides novel agents is maybe using some of the agents that we already have, either in different strategies or in different combinations to get the best outcomes for our patients.
Wonderful, thank you. And Dr. Perales, so what are your thoughts on what you've heard here and sort of moving the ball and forward? Area of room for improvement, but also some acknowledging some of our wins, so to speak. Yeah.
Yeah, so I concur with what my colleagues just sort of highlighted. I think one of the major advances, obviously recent advances, has been the use of post-transplant cyclophosphamide, which is now in many cases considered, at least in the reduced intensity setting, a new standard of care for GVHD prevention. Obviously, there are some issues with post-transplant cyclophosphamide, as there would be with any approach. There is an increased risk of infection, which is consistent with delayed immune reconstitution, which we've seen particularly in the randomized trial. There was a correlative science study looking at the recovery of the T-cell repertoire, and work that Leslie Keane led clearly demonstrates the difference between immune reconstitution and recovery of the T-cell repertoire in patients getting post-transplant cyclophosphamide compared to standards of care. I think there are also some potential toxicities from the high-dose cyclophosphamide, and so one of the big efforts we're seeing currently at many centers, including in multi-center trials led by the CIBMTR, is looking at optimizing the dose of cyclophosphamide and seeing if we can achieve a similar control of acute and chronic GVHD with lower doses of cyclophosphamide. And so there are trials ongoing. There are also a number of trials combining cyclophosphamide at lower doses with other agents, such as abatacept or ATG. Many of these studies are small, single-center studies, so may not be that informative, since I think in this setting it's really important to do the controlled study to see if we can change the standard of care. The other setting that was mentioned was the graft manipulation. Obviously, we have a long history at MSK of working on CD34 selection. That was tested in a large randomized phase 3 trial through the BMT-CTN. That was BMT-CTN 1301 or Progress 2. And that study ended up being a negative trial comparing post-transplant cyclophosphamide in the ablative setting with bone marrow alone, tacrolimus methotrexate with bone marrow, and the CD34 selected PBSC graft. The primary endpoint was chronic GVHD relapse-free survival, and there was no difference between the three arms, but there was increased mortality, treatment-related mortality with CD34 selection, which we now think is due to delayed immune reconstitution and toxicity. And we've continued to do work in this area to try and improve CD34 selection, at least as a platform for potential additional graft engineering. And finally, I think one of the points that wasn't mentioned is that we have a very well-known approach to reduce chronic GVHD, which is to use bone marrow. And this was also shown in a randomized trial through the CTN. It was one of the first trials that the network did and published in the New England Journal, bone marrow versus PBSC from a much time later donor, and that showed less chronic GVHD with bone marrow use, and in a subsequent analysis by Stefan Lee, also better quality of life in patients. And one of my favorite quotes of Dan Weisdorf, when he gave an honorary lecture at our national tandem meeting a few years ago, was that if we use bone marrow instead of PBSC, we'd have a much bigger impact on chronic GVHD than many of the small molecules we're testing for treatment of chronic GVHD.
I think the only thing maybe to add that might be a useful point, there's just published a analysis from the CIBMTR registry looking at the impact of post-transplant cyclophosphamide in different donor settings compared to a traditional backbone of a calcineurin inhibitor. And what was interesting was they looked at patients who were receiving a HLA matched unrelated donor transplant or a partial kind of mismatch, right? Usually a 7 out of 8. And even in that setting, when you would think there'd be more GVHD for the patients who received 7 out of 8, which there was, but when you compare the different GVHD prevention protocols, there's actually less GVHD with a mismatched transplant getting PT-Cy than there were with patients who had a full match getting the kind of formerly used calcineurin inhibitors, especially when it came to chronic GVHD. So really just kind of emphasize the point of also how we are now being able to expand our ability to give a safe and effective transplant, even for people who don't have a full match, which was a major limitation for our field decades ago, and has really been a major advancement for us.
Number one, there is now a donor for everyone, which was not necessarily the case when I first started, and there were patients where we couldn't identify an appropriate donor. And number two, I think the incidence and the severity of chronic GVHD has decreased. I mean, the patients we used to see, 20 years ago with that really fibrotic, debilitating chronic GVHD, I just don't see those patients anymore. And so I think we have better approaches to prevention. We have better HLA matching in terms of donor selection. And I think just in general, outcomes have improved for our patients.